Hello, I'm Dr. Carey. This is Dr. Carey's Baby Care. I'm a pediatrician in Ventura, California. Today, my guest is Esteban Bonfante, who is a pediatric gastroenterologist, and we will be talking about lactose intolerance and food allergies. Welcome.
Thank you. Thank you for inviting me.
I appreciate you coming. You know, when I went into medical school, I thought, oh my, I want to do something from the waist up initially, so it was sort of an area I stayed away from. But pediatrics in general has a lot of gastroenterology involved in it, and it certainly covers everything from the mouth all the way down. And there are a lot of interesting topics. One of them that really can be confounding for the pediatrician and for patients is lactose intolerance, because everyone thinks that they're dairy intolerance and food allergies, and trying to distinguish that in babies and trying to figure out what to do. So Esteban, why don't we get some definitions out of the way so we can get a level playing field. What exactly is lactose intolerance?
Lactose intolerance is the deficiency of an enzyme that is called lactase. When there is deficiency of this enzyme, lactose doesn't get digested, and therefore there is malabsorption of lactose, and it may produce the syndrome of lactose intolerance that is formed by diarrhea, this abdominal distension, flatulence, and bloating.
Okay, and in babies, it's really a very rare event for a baby to be born with primary lactose intolerance, correct?
Correct. It's very rare. It's very rare for a baby to have lactose intolerance. As a matter of fact, they wouldn't have survived before the production of lactose-free formulas, because it's the main carbohydrate in milk.
Right. And yet there are different types of lactose intolerance, not just primary lactose intolerance, in which that enzyme is gone, that can develop starting from when a baby is born premature to when they get sick. Would you want to elaborate on that?
That's correct. Babies before 34 weeks of gestation have some degree of lactose intolerance, but most of the lactose is produced when they are a full term and they are ready to feed. If they get a secondary infection and there is an injury to the lining of the intestine, then the lactose may go down, the levels may go down, and secondary lactose intolerance may be produced because of the inflammation.
Okay, so you have two groups. You have the premature child born before 34 weeks who really is lactose intolerant, but then by the time they hit 35 weeks or so, they have enough enzyme to be able to digest milk.
Correct.
And then you have the other group who is a healthy population who gets sick, and the gut gets inflamed, and then they become lactose intolerant.
Correct. Temporarily, it's a transient condition. Once the lining of the intestine heals, lactose is present again.
And what kind of infections usually cause things like
lactase is present again. It could be a viral infection, most commonly rotavirus. Now we see less rotavirus because of the vaccinations, but it could be also other viruses like novovirus, or bacterial infections, or could be even parasites in older kids like Giardiasis is another possibility.
Go ahead.
No, I was just going to say that other inflammatory conditions like cow milk protein allergy can also produce a decrease of lactase in the intestine.
Perfect. So let's talk about lactose allergy also then, and how does one define and distinguish that?
Okay. Well, there's the way of distinguish is because the inflammation produces diarrhea that is characteristic of inflammatory diarrhea.
Okay.
The inflammatory diarrhea is formed with leaking of cells into the intestine, and we can detect those cells in the stool. When there is lactose intolerance, it's just a maldigestive diarrhea, and it won't produce the same symptomatology as in the inflammatory diarrhea. A way to distinguish between them, it could be by detecting occult blood in the stools.
So when we see blood, and by occult blood, you mean you may not even be able to see it necessarily?
Not necessarily. It may be microscopically, and that will be an indicator that there is an inflammation associated with the diarrhea.
Okay, so allergy can cause inflammation in the gut that can lead to problems with lactose. But how are these children coming to the office? What are the parents concerned about? What brings them to you?
Because baby is uncomfortable, because there's bloating, there's diarrhea, there's gassiness, and sometimes they may even have reflux after these symptoms because of the bloating. But most concerning is the diarrhea. Mm-hmm. And sometimes they may even see the blood, and this is very scary for them. But once the inflammation is gone, usually the lactose intolerance resolves.
Okay, so you have a newborn and they're coming in, but boy, a lot of newborns come in gassy. I mean, I hear that all the time, and my child has colic, and they go on and on and on about this. How do you know what's going to alarm a person to say, gee, my child has more than just typical colic? Is it usually the blood, or is it just really watery diarrhea? How exactly does it look?
That's right. It could be either that they have diarrhea. Mm-hmm. It could be that they are failing to thrive. They are not gaining weight properly. And that's one of the warning or red flags that there's something wrong, and there's need for more investigation.
Okay. And if they have allergies and they have some blood in their stool, are they likely to have other signs or symptoms along with that?
They may have other signs like eczema. That's a common association with allergies. Mm-hmm. They have the failure to thrive, and they may have irritability. They may look well too.
Okay.
But eczema is a common association with the cow milk protein allergy.
Mm-hmm. What tests is the pediatrician likely to do at that point before they even see a gastroenterologist? If a parent brings in their baby and says, boy, we have some blood in the stool and my child seems really gassy, some diarrhea, is the pediatrician likely to just treat empirically without doing anything, or should there be some tests that they should perform at this point?
There should be some tests, definitely. There should be stool studies ruling out the other possibilities, like an infection.
Okay.
The detection of cells in the stool, and what kind of cells, if possible, are present in the stool. Cultures.
What do you mean by cells in the stool? What specifically are you looking for?
We're looking for white blood cells that are immune system cells that leak into the intestine, and then we can see those in the stool.
And that really gives you an idea that there's a lot of inflammation going on there.
That's correct. Mm-hmm. That there is inflammatory, because and that's a main difference between lactose and cow milk protein allergy. Lactose is not an inflammatory type of diarrhea, so mm-hmm. we wouldn't see the cells that we see in the inflammatory diarrhea.
Mm-hmm. So now we have our child there. There's a high suspicion that we have let's say a food allergy. We've had some blood in the stool, some diarrhea, bloating. What's next?
Well, we will treat the cow milk protein allergy.
And how?
That will be with extensive hydrolyzed protein formula. Mm-hmm. The immune system is unable to detect this broken down formula, and they usually get better. Once the mucosa heals, the lining of the intestine, then the diarrhea subsides.
Now, a lot of parents will try treating with a soy formula prior to that. They're something's wrong, and I will get one parent after another. I mean, I think I had someone find 8 or 9 different formulas once that they tried for their child before they finally came in. I didn't know there were that many on the market. But what is the downside of trying a soy formula instead of jumping to something that's hydrolyzed that we know is considered hypoallergenic or a very low chance of having allergy to?
The downside is that many patients who are allergic to cow milk protein are allergic to soy protein too, up to 40% of them. Mm-hmm. So it may not resolve the problem. Mm-hmm. And many times they are not patient enough with one formula, and that's why, because the healing takes time.
How long does that take?
Usually 2 weeks.
2 weeks before you really start to see significant improvement in your child once you've switched to the right kind of formula?
Correct.
Mm-hmm. And yet, if any dairy is reintroduced, how fast are you likely to see a problem again?
If they have the problem right there, you'll see the problem. If the lining is healed already after 2 weeks, they get better. But if you introduce any dairy, when they have the inflammation, the lactase, the enzyme, is not there, and then they have the transient lactose intolerance.
Okay.
After 2 weeks, we could try to introduce again lactose.
And then, so we have our child again. We have switched over to the appropriate formula. They're doing wonderfully. Life is wonderful. What's the long-term prognosis? When can one introduce dairy again? Is there a point where they might be able to tolerate some dairy? Will they be able to go to a full dairy diet?
Most babies outgrow their cow milk protein allergy by 1 year of age. 90% of them do.
90%?
That's correct.
And will a few more outgrow it by 2 or 3 years, or will you get to about 95%?
That's correct, yes. By 18 months, then most of them are not allergic anymore. Okay. They outgrow the allergy.
Okay. And the secondary lactose intolerance that one sees from infection, that's going to heal, I'm assuming, once the infection is resolved.
That's right.
And how long will that process usually take?
And when the tissue is already healed. That varies depending on what was the original insult, what was the original infection. If it was a bacterial, it may take longer because the lining recovers in a slower type of time. Also, patients with celiac disease may have inflammation in the intestine, and they may have lactose intolerance.
That's a whole other topic unto
That's
itself.
Another.
Well, Esteban, thank you very much for coming. I really appreciate it. I think we've learned a lot about lactose intolerant and food allergy, and it can be really confusing sometimes when a baby comes in with some of these problems and you never quite know which way to go with it. I am Dr. Carey. We have a lot of interesting information on our website. I hope you come and visit at drcareys.com. We also have a wonderful newsletter. Please come and sign up for that. And remember, at Dr. Carey's, we teach baby care.
Breathe in, breathe out. Breathe in, breathe out. Okay. Let me see your ear.